raise awareness on the following three questions. First, what are the needs of affected people? Second, what are the challenges they face? And third, what are the key practices to address them? Before starting our discussion, I would like to thank the Republic of Guyana, co-winner of the Nobel Peace Prize, Humanity and Inclusion, and the Civil Society Engagement Mechanism for Universal Health Coverage UHC 2030 for co-organizing this event. Today's discussion features panelists from a variety of backgrounds, gathering representatives from civil society, academia, international organizations, and member states. I'm confident that the diversity of their experiences will enable us to shed light on this important topic and allow for fruitful discussions. So let me pass the floor back to Mr. Burdin, who, as he said, is a former BBC Africa Bureau Chief and who will continue to moderate this event. Welcome to all and have a good session. Thank you.
Marianne, thank you very, very much for that very inspiring introduction on why we've all come together today to discuss this important topic. I think, as you say, we have a truly international panel, and I'd like to introduce you to Dr. Alaros Cieza, the unit head at the World Health Organization. We also have Dr. Baghetta from Canada, who's currently an associate professor at Duke University in the US. We have Smita Sadasivan from Chennai in India, Dr. Manga, the Director of Rehabilitation from the Ministry of Health in Guyana, and we have Florence Dunis, who's the Director General for Humanity and Inclusion, who will be speaking from France. Just before we begin, very, very briefly, a few housekeeping points. This event will be recorded and made available publicly afterwards. So anyone who doesn't give their consent to the use of images are asked just to keep your cameras off during the event. We have a captioning service which will be streamed via this link, and that will be pasted in our chat box. And as you can probably see, Ramon Wolf doing a marvelous job as a sign language interpreter, and he appears as one of the panelists for people who want signing throughout this important session. After the panelists' remarks, we'll have an opportunity for questions. So just type your questions in the chat box, and I'm getting a few already. As Marianne Mark says, our discussions will examine two main areas. In part one, our panelists will address the global needs and challenges. And in part two, we'll look at some good practices and key recommendations for the future. But first of all, let's have a look at why we're all here with this short video from Humanity Inclusion on looking at the importance of rehabilitation around the world. So if we're ready, we will have that short video now. Just a few seconds, hopefully.
$2.4 billion people globally need rehabilitation, yet more than 50% of people do not receive the rehabilitation services they require, a percentage that increases in low and middle-income countries during and post-conflict. In particular, persons with disabilities face significant barriers to access rehabilitation. Rehabilitation enables persons to achieve and maintain their optimal physical, mental, and social functioning in their everyday lives and to fully participate in society. Rehabilitation consists of different measures, including the provision of assistive technologies, and everyone might need it at some point in life due to conditions present at birth, diseases, aging, or due to injuries, including those caused by conflicts. Improving the access to rehabilitation services is necessary to ensure healthy lives and promote well-being for all at all ages. Everywhere, in both urban and rural areas. And it is instrumental to comply with the Convention on the Rights of Persons with Disabilities and the Convention on Cluster Munition. Building on the initiatives Rehabilitation 2030 and Global Cooperation on Assistive Technology by the World Health Organization, it is time to integrate rehabilitation in health systems and at all levels of the health pyramid via sound policies that ensure financial coverage for rehabilitation services and assistive technology, increasing and training the rehabilitation workforce, investing in research and innovation, and foster collaboration with other relevant sectors. Let's work together to make rehabilitation accessible to everyone, because without rehabilitation, there is no health for all.
That video there from our colleagues at Humanity and Inclusion, and we can move to our panel discussion with those words. Without rehabilitation, there is no health for all. So it just places rehabilitation at the center of everything. Just looking at our panelists now, I'll just do a quick roll call. Do we have Dr. Cieza with us? I fear there might be some technical problems. Or Dr. Bedgeter. I think we're very sure. Aha, wonderful.
I'm here.
Elazar Cieza, very nice to see you. I mean, as we were hearing in the opening remarks from Marianne Marks, and also from that video, that really in your role at the World Health Organization, could you please frame for us rehabilitation in terms of global health needs and challenges? I mean, where does rehabilitation fit into the equation?
I'm very keen to do that. And you see in my background, it's about health for all. So, and also rehabilitation contributes to health for all in the context of universal health coverage, and what it was emphasized so greatly in the video from Humanity and Inclusion. Let me also emphasize one of the messages that the video has already provided, and it is that there is 2.4 billion people globally who have a health condition that needs rehabilitation. And I want to emphasize this number because this number also shed light and emphasizes the scope of rehabilitation and the broadness of rehabilitation. So rehabilitation addresses the need of people with musculoskeletal conditions like arthritis, neurological conditions like, for example, a stroke, pulmonary conditions like asthma or chronic pulmonary diseases, cardiovascular diseases like ischemic heart disease, and also injuries like brain injury or amputation. But also what we forget frequently is that we are talking also about conditions such as severe vision and hearing impairment, and persons and people from all ages. And actually the scope of rehabilitation does not only stop there, because in these numbers, in the calculation of these numbers of the 2.4 billion people, we only consider conditions that are chronic, that stay with us for a long time, but not we didn't consider infectious diseases. But one of the things that COVID-19 has also showed us, and of course at this time we need also to talk about COVID-19, is how also rehabilitation can be fundamental for addressing the needs of infectious diseases such as COVID-19. We have seen that rehabilitation is fundamental for addressing the acute needs and, for example, respiratory need in intensive care, but also the short and long-term consequences of COVID. Now, many people living with so-called long COVID or post-COVID-19 condition were experiencing fatigue, cognitive impairment, and also other limitations in functioning, and rehabilitation has also a role to play there. And the last point in terms of the context and the scope of rehab, we have seen that this need has increased tremendously over the last 20 years. And what we can expect is that this need will continue to increase. And because the population and health trends, people living longer, but of course also living longer with more chronic conditions. So we need to take that into consideration. Then you asked me to another question that was, where does rehabilitation stand? And I have to say that unfortunately, and despite this huge need, rehabilitation in countries usually is under-prioritized, under-resourced, and completely undervalued. And there are, of course, many reasons that lead to that. And one of them is also that we have been over years putting rehabilitation in a small box. I always describe sometimes it's like putting rehab in a small box and saying that rehabilitation only benefits persons with long-term disabilities. But we see, and that is what these numbers portray, that is not the case. But putting rehabilitation in that small box has led also to being under prioritized and undervalued, and also in countries even has been taken away from the health sector and moved to, for example, the social sector, where frequently has been even more under prioritized. Also, this perspective of seeing rehabilitation as a strategy only for persons with long-term disabilities or long-term impairment has also led in many countries to provide rehabilitation services only from the perspective of NGOs or only from charities. What it is important, however, what we have seen that then the services have not been integrated, and rehabilitation has not been integrated as part of where they need to be, as part of health services along the continuum of care, as I have mentioned before, in acute, post-acute, and long-term care, but also at all levels of the health sector, as it was also mentioned in the video, at primary, secondary, tertiary level, and also delivering the community. I think you also mentioned that I should point out to what is missed to respond to this increasing need. And let me mention an important point that is, and actually I would mention three things that from the perspective of WHO we are saying that are missing. The first one is awareness, and awareness by policy makers that rehabilitation is fundamental, that needs to be integrated in health services and need to be provided as part of universal health coverage. And really, I want to thank now at this moment the government of Luxembourg and the Cooperative of Republic of Guyana for co-sponsoring this event, because we need many more of those, really bringing rehabilitation to the attention of policymakers. But it is also the awareness that needs to come to healthcare providers as a whole, or the healthcare workers as a whole, because there are many people living with limitations in functioning, for example, loss of mobility, or the loss or the with vision, hearing impairment, that it is even perceived by healthcare providers as natural developments of certain health conditions or natural developments of the aging process. And it is not perceived as a need that needs to be identified and addressed with rehabilitation. And that is the reason why awareness among the broader health workforce is absolutely fundamental. And also, and also because we need to think how much helplessness, dependency, and also loss of productivity could be avoided if really those needs could be identified, for example, at primary health care by healthcare providers of primary health care, and then to refer to rehabilitation services. And also, yeah.
Fantastic. No, I think there's a lot there, and we'll return to these themes. I mean, I pick up on word rehabilitation undervalued, rehabilitation poorly resourced, and of course, as you rightly said, we sit in the middle of this global pandemic. I'd like to turn to a colleague of ours, Dr. Janet Betka, who is currently an associate professor at Duke University, and she has been doing research into COVID-19 crisis and particularly rehabilitation and health services. Dr. Betka, what is your perspective? Is anything working well? Janet, I think you might be on mute. Can you hear me? Not getting your microphone. Can you say a few words, please? If you could can you see the audio button? Or is it just not, it's not coming through at all? Maybe we'll return. Let's move over to India and Smita. Hello, Janet, you're there. Can you hear us now?
Oh, I'm so sorry. I'm not sure what the problem was.
That's fine. That's fine. As I was just
I apologize
saying,
for that delay and the challenges there. Thank you so much to the program sponsors and planning group for including me. And those two critical questions I will address now in a little less time. I'd like to go through a couple of slides so that people attending today have some reference for these points. And I'd like to reflect that these comments actually represent collaborations with over 200 people globally. As we just heard, and some really critical points already made, 1 in 3 individuals globally would benefit from rehab services, and these data were largely were generated before the pandemic. And so I'd like to first focus on research that we had started with just a month into the COVID pandemic, because recognizing the need globally, we collaborated with 12 low, middle, and high-income countries to describe the impact of COVID on rehabilitation services. And importantly, as was just presented, we wanted to understand rehabilitation services of all types, and we used the Rehabilitation 2030 Rehab and Health Framework to help us do so. And the reference for this is provided there. Here is what we found early on, and so thank you for this question about the impact of COVID on rehabilitation services. We considered that if, hypothetically, all service types were evenly distributed and available prior to COVID in all countries, we wanted to know what impact did the pandemic have. The stories were devastating, just truly remarkable as we shared just day to day and week to week how things were changing. And stories were at the same time similar across different countries, but with varying levels of intensity and impact. If we look first at the top row, and the consideration of rehabilitation beds, highly specialized care. What we see is, and by moving these icons, if you can follow along, is that rehab beds converted quickly to be reduced, unfortunately, to make increased capacity for acute COVID beds. It delayed inpatient rehab admissions, it shortened length of inpatient stay, it led to early discharge, and unfortunately, as you see here, the distribution of those patients Some of them were able to be cared for in outpatient care if their needs could do so, but most were discharged home with very little training, impacting families and caregiving, and without continued services. If we then consider outpatient rehabilitation in, for example, clinics provided still with specialty care, it was largely suspended in all countries, was offered at reduced service capacity where it was still offered, and in some places where there was the opportunity to leverage telehealth, that was made available. But most of these patients were asked to manage at home. We then see the distribution of services as it relates to rehab integrated with primary care. For the most part, these stopped at the outset of COVID because primary care had to allocate resources for COVID testing. Some of these patients received telerehabilitation again where available. Otherwise, most of these patients were asked to manage at home. Community delivered and home-based rehabilitation were limited to critical services only to prevent transmission, and in many of these cases, unfortunately, countries were without adequate protective equipment for rehabilitation professionals in the community or providing services at home. And so what we ultimately saw was the predominant, the largest proportion of patients who initially would have been receiving rehabilitation services were now managing at home, largely without ongoing direction as would have been provided otherwise. Recognizing that rehabilitation focuses on the functioning of an individual and not the disease, we're now faced with a situation where individuals without COVID had escalating needs, literally measurable disability within a week of inactivity. And now we had this new population of individuals with needs as a result of COVID that we were still learning about. This was early on in the pandemic, and so I wanted to quickly highlight three important advances that emerged during the pandemic and the year that followed. A month after our 12-country assessment of COVID's impact, our team at Duke reached out to the Institute for Health Metrics and Evaluation to begin to define the burden of COVID. There was significant attention, as we all remember, early on mortality. And at the time, there was very little discussion on persistent symptoms or long-term effects. So we completed a systematic review. Many of these are still ongoing. And IHME included cohort studies from several countries to ultimately have a collaboration of 75 contributors into a manuscript that's now under review to define long COVID disability. These are data we need in order to build capacity within countries moving beyond this pandemic. Partnerships were critical, and here I highlight three types. As an example of partnerships across organizations, the Global Health Alliance released a position statement in June 2020 calling attention to rehabilitation as an essential health service during and after the pandemic. As an example of partnerships across healthcare professionals, this past June, 54 individuals collaborated for a World Physiotherapy paper on safe rehabilitation approaches, focusing on physical activity and exercise in particular for people living with long COVID. And third, as an example of partnerships across sectors, Singapore had expanded the UK model for social prescribing to offer it for rehabilitation patients. With COVID, they pivoted to address the digital divide for their patients without internet, without technology, without digital literacy skills. Despite the impact of COVID on rehabilitation services, this model continued. Patients were still connected to resources that address their social determinants of health and socialization. This model received the 2021 International Social Prescribing Network Award. Finally, I want to comment on the opportunity for telehealth. The digital divide exists everywhere. It's clear between key demographics, notably older and younger individuals, but also those on the lowest and highest incomes. We see this at an individual level, we see it nationally. In our initial study, we outlined recommendations in order to ultimately support telehealth as a strategy to increase access to rehabilitation. We saw these changes happening quickly over the last year. And last fall, I was especially encouraged by activities in Tanzania, where technology had played no role in rehabilitation to that point. However, the Ministry of Health supports rehabilitation in Tanzania and supported the development of a text and telephone-based strategy in northern Tanzania for physiotherapists to address their second leading cause of disease burden, That's musculoskeletal pain, particularly in the low back. So despite the initial devastation to rehabilitation services and the impact on individuals with rehabilitation needs prior to and new during the pandemic, I feel encouraged by the advances of this past year, and I'm confident that increased awareness on the crucial role of rehabilitation can lead to policies and action that will help us address the needs globally. Thank you.
Janet, thank you very much. Absolutely fascinating and great to have that real contemporaneous study on what is actually happening as we still sit in the middle of this global health pandemic. Actually, I think this is affecting the entire world, but I think some of the most distressing images we've seen of health systems creaking under enormous pressure have come from India, particularly as the Delta virus hit so devastatingly there. So I'd like to turn to Smita Sadisavam from Chennai in India, who works on a project with to try and achieve independent living, the kind of things which Dr. Janet was mentioning, independent living for people with disabilities. I mean, very much, Smita, from a user's perspective, what do you think are the key barriers to accessing rehabilitation services, both during COVID and, of course, beyond COVID? And how do these barriers affect marginalized groups?
Am I audible? Yeah. Thank you, Mr. Burden. Good evening and good morning to everyone. The key barriers to access rehabilitation services. First one, I would consider as poverty. Most of the estimated 2.4 billion people who need rehabilitation, as per our survey, most of them are living in poverty and in low resource settings, and most of them are in low and middle income countries. And then another barrier is about lack of access to information. Even if some people can access information, they are not able to use the information on time because they don't have the means for it. Like, for example, I mean means as money, transportation, and personal assistance, etc. And with regard to persons with disabilities, it is more on inaccessibility to infrastructure, healthcare infrastructure, or information and communication technology. So all these are barriers in the rehabilitation system. And apart from that, another major barrier is lack of availability of services. So largely rehabilitation services are available only in cities, and it is far away for poor people who are living in villages to reach, and many are daily wages and time is a precious commodity to them. And another barrier is, as Dr. Alakas mentioned, is inadequate resources. There are only 10 skilled rehabilitation professionals per every 1 million population in low and middle income countries. This is really a threat to our health system. And all these inequities are growing multifold during COVID, and millions of people are getting into abject poverty and acute hunger. Even from my own personal experience, though I am sitting in a metropolitan city and at a easy reach for with different services and under the care of a health NGO like Multiple Sclerosis Society of India, Chennai, I am also facing a lot of issues with regard to my rehabilitation. My physiotherapist is not able to come reach me during the lockdown, and online therapy is not really very effective. And because of reduced mobility, I am developing a lot of health issues, and which leads to look into other different therapies, specific therapies, which are more expensive. So one problem leads to many other problems. And similarly, at different levels, like for example, the vision therapy equipments have to be changed. It's been 2 years, but then I'm not able to go to the eye hospital for a checkup and get that changed. Or a person with a multiple sclerosis who is bedridden, she needs a standing aid for standing exercises, but her aid is worn out, and she's getting injured because of it, and her parents are finding it literally difficult to find out an agency who can provide an appropriate aid. And right now she cannot be carried to another district, CMC Vellore, where they can provide the appropriate aid. And there are many families who are committing suicides because they are not able to care for their vulnerable family members or because of poverty. And so many such cases are happening, and mental health services are literally at stake. Even people cannot access their routine medicine for their mental health services. And so these barriers are bound to grow phenomenally over the next coming years unless adequate investment is made in primary healthcare and community-based initiatives with a greater degree of political will. So this is what UHC 2030 and civil society engagement mechanism is also promoting, that we should strengthen our health system, and countries should invest into UHC, and UHC should cover all the needs, all the healthcare needs, including rehabilitation, so that no one is left behind. And your second question is about how do these barriers affect marginalized groups, including persons with disabilities. So persons with disabilities are being excluded, and similarly other vulnerable groups also, from all aspects of life because of all these barriers. Say, for example, childhood, play, education, livelihood, relationships, social and political participation. So eventually they tend to become a burden to their families. They feel dehumanized and are subject to deprivation and other mental health conditions. We all know that the cost of exclusion is much higher than providing essential healthcare and rehabilitation in the community. And when we are talking about healthcare and rehabilitation services in the community, it should involve task shifting approach, which the WHO should consider in their 2030 rehabilitation agenda. And I would like to wind up with a couple of key calls for action from the civil society engagement mechanism to UHC 2030, which is invest in the health force, including evolving a cadre of local community health and rehabilitation workers in order to deliver quality, people-centered and doorstep care. The next point is about having national health plans and policies which should prioritize the most vulnerable populations and include them in decision making. And finally, increase public financing for health so that the countries can have UHC policies which cover everyone. No one is left behind for all their health and rehabilitation requirements, so that nobody experiences financial hardships in their healthcare and maintenance, and no need of out-of-pocket expenditure. Thank you very much for the opportunity.
Smita, thank you very much for sharing that with us, and that very, at times, very stark picture of what is actually happening for people who need rehabilitation, what is actually happening on the ground. When you say 10 health professionals per million people, that really is a very stark statistic, which sums up a lot of the things which you went on to say, but also that hope you gave for the future of your prescription of how things can improve for rehabilitation. I'd like us to return now to Marianne Marks, really, to introduce our next session, where we examine good practices and some key recommendations on how we build stronger, more resilient and more inclusive health systems. Marianne, we've heard some very good case examples. We've heard a lot of good statistics. How do we actually move forward with this? Hi, Marianne.
Yes, thank you, Peter, for your question. Indeed, in response to the global needs and challenges that were just illustrated by the three previous speakers, Luxembourg has always remained committed to supporting rehabilitation, particularly in situations of poverty and fragility. I will first focus on our strategy and will then highlight a few rehabilitation projects that the government of Luxembourg supports. So first on the strategy. Based on the recognition that a large number of people globally are pushed into poverty as they lack the most basic health coverage, ensuring access to health service has ever since been a key component of humanitarian activities. Striving to leave no one behind, like Smitha mentioned before, Luxembourg has always put the most vulnerable people living in fragile situations and in insecure areas at the center of its efforts. We are very present also in the Sahel region, for example, reflecting our belief
Marianne, can you hear me? Hi. Marianne, we seem to have lost audio. Ramon, can you hear anything? No. Marianne, can you hear me? Hello? We can't hear you. We've lost audio. Let's, we'll return to you in a few moments. We'll sort that out. Let's go to our co-sponsor, the Guyana Ministry of Health, and Dr. Ariam Manja, who is helping us with our understanding. Marianne, we'll return to you in a few moments, if we may. Now, covered Dr. Manja in Guyana. We can hear you fine. Marianne, can we hear you?
I can hear you, but can you hear me now?
We can hear you now. Yes, we can hear you now. If you could just keep that going very, very briefly, and then we'll bring Dr. Ariam Manja from the Guyanan government as well. So, Marianne, you were just talking about your strategy, your work in the Sahel, the need to leave no one behind, and the kind of work which Luxembourg government is doing around the world. Is there anything you would care to add at this point? Now we've got you back.
Yes, and sorry about this. I kept.
I'm so sorry, we've lost you again, I think. Yeah. Marianne, we'll move on to Dr. Marianne Ariam Manja. Can you hear me? I do apologize to our audience.
Good morning.
Hello, Dr.
Can you hear
Manja?
me?
Yes, we can hear you. You go ahead, and then we'll talk to Marianne a little bit later. So thank you very much for co-sponsoring this event. If you could tell us a little bit about what you're doing as Director of Rehabilitation Services at the Guyana Ministry of Health, please.
Good morning, Peter. Firstly, I'd like to take the opportunity to extend my gratitude to Handicap International, the government of Luxembourg, and the United Nations for extending this platform to us to not only showcase rehabilitation in Guyana during the COVID-19 pandemic, but also to showcase the importance of rehabilitation in helping countries to attain Sustainable Development Goal 3, promoting healthy lives and well-being at all ages, rehab for all, health for all. In Guyana, the government has been increasing resources towards rehabilitation and also increasing the workforce as we move ahead. Guyana's population is currently 785,000 people, and our first case was on the 11th of March. To date, we've had over 20,000 cases of COVID-19 and over 450 deaths. You know, currently the world as we know it is no more, and we are facing a global health crisis unlike anything we have ever seen. COVID-19 came like a thief in the night, which upended Guyana's economy, forcing the government at the time to implement a countrywide lockdown. Borders were closed, stay-at-home orders for non-essential workers were implemented, which meant that rehabilitation services had to stop in Guyana. And, you know, to prevent massive loss in strides, we reopened clinics 2 weeks later, but only professional staff worked. And by the 3rd week, we started tele-rehab. In Guyana, the internet is very dodgy. However, we were able to meet our patients via WhatsApp and phone calls and so forth. Before COVID-19, it was said, you know, as many of the presenters would have alluded to, that 1 in 3 people will need rehabilitation at some point in their lives. And much too often, the needs are unmet. Rehabilitation is an essential service, as we are aware. People didn't stop having strokes, amputations, disability did not disappear, and hearing did not miraculously reappear. So although scaled down, we had to find a way to safely reopen all our outpatient services. So guidelines to safely reopen clinics were developed, and clinics were reopened, albeit scaled down. And we started with only professionals, and we restarted our outpatient services and continued our tele-rehab in our version of it. On May 6th, in 2020, we saw our first COVID-19 patient, and they were referred for therapy. And from March to August, all our COVID-19 critical patients were seen at the Georgetown Public Hospital. To date, I can say we've seen over 2,000 COVID-19 patients. However, as of August 2020, the government of Guyana, they developed a specialized hospital to treat only COVID-19 patients. And presently we have 2 physiotherapists permanently stationed there, and the speech and occupational therapists, they work on call there. So this is another way in which the government would have improve services so that we could have dealt with the pandemic. This is the new norm, and it's hard to believe how much has happened in the last year. All in Guyana has stepped forward, and the government has been very supportive of our rehabilitation services. In February 2021, the government of Guyana provided vaccination for all medical personnel, which included all our rehabilitation staff. And this has been a tremendous boost in the morale for staff, because now they're more willing to work in the departments and with COVID-19 patients. To date, 85% of the rehab staff have been vaccinated. You know, we're seeing more post-COVID patients. We're doing more to make people aware of the services we offered. We've hired more physiotherapists and occupational therapists. We've also deployed therapists to the hinterland and rural areas to help to strengthen the services we offer to the patients. And this is just some of the work that we've been doing. And looking forward in Guyana, there's distinctly a need for us to resuscitate and strengthen our community-based rehabilitation to ensure optimum community participation, as well as to help to fill the gap in areas where we lack rehab professionals. Community-based rehab may be a strategy that may be used in rehabilitation services to contribute to helping countries, not only Guyana, to attain Sustainable Development Goal 3. So this is definitely something that we will look at to integrate more to strengthen our healthcare services in Guyana. As I said, we look to employ more therapists, and this is from the government's end, and we're looking to develop and implement a new strategic plan for rehabilitation in Guyana to streamline the services we offer and to be more in line with World Health Rehab 2030 strategy. We'll continue to highlight the services we do, and rehab has really come a long way. And with the support from various health ministries, I'm certain that we will be closer to attaining the Sustainable Development Goal 3 whilst taking rehab to that next level as we strive to build and strengthen rehabilitation globally. And governments will definitely need to pivot their views on rehabilitation if we want to attain this goal. Thank you.
Marianne, thank you very much for that. And I'm sure what you're doing in Guyana is something we would all love to see rolled out as a blueprint in many other countries as well. And very much thank you, Marianne, for the positive approach in Luxembourg as well. I can see our chat box is filling up fast, and I'm keen to move to bring some people in with some questions. But just before we do, I'd like to bring in Humanity and Inclusion's Deputy Director, Florence Donis, because as we know, HI operates all over the world, particularly in terms of people of disability. Florence, how has HI adapted its operations to continue responding to the needs of rehabilitation across all its projects? Hi, Florence. We can't hear you. There we go. Florence, you're there? No, we still can't. Can we hear you? Are you on mute? Florence, I don't think we're getting you. We'll come back to you. I'd like to bring in questions for any of the panelists.
Can you hear me? Can you hear me?
That's lovely, Florence. Yes.
Good.
Fire away. How has HI responded to the rehabilitation needs across all your projects? Do carry on.
Thank you very much, Peter, for this question, which is particularly meaningful when I think about what HI rehab teams spend their time doing all 2020. Past the moment of astonishment, adaptation has been indeed the key words for all our team, and the how had been taking different phases. And let me start by saying that I am honored to be here today with a wonderful panel of speakers and pleased to share a few insights about how we made it happen. As Peter introduced, you introduced humanity and inclusion. Let me just say that we currently operate in 50 low and middle income countries with 265 projects encompassing a wide spectrum of areas. 69 projects concerns rehabilitation and assistive technology. When COVID-19 broke out, as Janet showed us before, it appeared clearly that health systems, especially in already fragile contexts, were not able to continue responding to other health needs while managing the pandemic emergency. The provision of rehabilitation services was very much disrupted. In this context, it had been important to ensure some continuity of rehabilitation services for the person for whom rehabilitation is essential for their health, functioning, quality of life. As we were all learning more about this virus and its effect, it seemed more and more obvious that people severely affected by COVID-19 have rehabilitation needs that could be divided into the acute phase, when receiving ventilator support, the subacute phase, still hospitalized but no under ventilator support, and the longer-term phase of care following the discharge. Therefore, we had to take into account and respond to these new additional needs too. In all this, we had to ensure, of course, the adequate protection for HI staff, partners, beneficiaries, and the rehabilitation professional involved in our projects. So in order to adapt at best our rehabilitation operation, we did rapid need assessment for rehabilitation service users to take into account needs in an holistic way and to prioritize. Funds of ongoing program were reoriented based on findings and in agreement with donors when relevant.
And depending on the level of severity of the health crisis in a given country, we had adopted different measures. Let's go through those different levels. Level 1, as we decided, was country facing few or no cases of coronavirus. In that case, rehabilitation activities have been continued at all levels, in communities, in rehabilitation centers, in hospital, in strict compliance with IPC recommendation. We consider this as preparedness stage, crucial to enhance the dissemination of key messages on the prevention of complication, home exercise program, as well as the supply of technical aid. Level 2 was country facing a significant numbers of coronavirus cases with pocket of epidemic in some areas. Activities at the community level have been put in standby, and when possible, followed up remotely with hotlines, WhatsApp, those kind of things. Activities in hospital and rehabilitation centers have been continued in strict compliance with IPC recommendation and with significant reorganization to regulate the patient flow. We have maintained in priority service for people at risk of complication or who might develop secondary impairment. Finally, the level 3, the countries that are facing a very high contamination and mortality rate. Activity have been maintained only at the hospital level, focusing on early rehabilitation care for injured people or people with newly acquired impairment. At this level of severity, all other rehabilitation activities have been put in standby with the possibility anyways to implement some remote follow-up. So basically what we heard about our colleague in India. Besides what I just mentioned, HI advocated for and supported authorities in developing inclusive risk communication campaign and national guidelines for COVID-19 response. And we collaborate with WHO to make sure that COVID-19 rehabilitation guidelines were meaningfully adapted to low and middle income countries. In addition to this three-phase strategy of intervention, online rehabilitation has enable thousands of patients to continue their session at home by connecting with rehabilitation professionals by video, via WhatsApp, or simply by receiving check-ins and new exercise by phone. In the past months, HI enhanced the deployment of telerehabilitation in countries like Bolivia, Cambodia, Colombia, Nepal, and Rwanda. The purpose is to prevent complication and maximize functionality for persons who face a high risk of developing comorbidities if they do not receive rehabilitation services, for instance. Telerehabilitation was made available by HI for people who already received an in-person rehabilitation session or at risk, or having a prescription or recommendation for follow-up, or without access at all to rehabilitation services. Telerehabilitation works well, we believe, if some conditions are respected. There needs to be a one face-to-face session for assessment. Indeed, the user needs to be educated to effectively use the platform, and the user needs to commit to education exercise and weekly monitoring via video. Different types of technologies, modalities, and software can be used, and the choice depends really on the analysis of the context. For example, the availability and the quality of smartphone and of the internet connection. In contexts like refugee camp, we almost no access to communication technology. The best strategy was to further mobilize community-based workers and volunteers to ensure a minimum level to follow up for people who couldn't access rehabilitation services anymore because of movement restrictions. As conclusion, I will emphasize that beyond the COVID-19 pandemic, telerehabilitation can really be a game changer for persons living in areas where rehabilitation is not accessible, not affordable, or not available.
Thank you very much, Florence. And it's interesting how telerehabilitation is emerging as a key theme of this session, actually. And we heard earlier how it was being used to great effect in Africa, in Tanzania. Just before we move to a Q&A, and I'm getting the questions now, I'd like to return to Anne-Marie Marx of Luxembourg just for her thoughts on what she feels is the best way forward. Anne-Marie, if you can hear me, please come in. I fear we're still having a difficulty. I'm not sure what it is. Yeah, Anne-Marie, I'm terribly sorry. Can we come back to you after the questions and answers, and maybe someone can assist with the audio from there. On the questions and answers, really looking at community engagement, it would be excellent if we could bring in Dr. Arya Manga and really look at, what is the role of the community? We talk about rehabilitation services. Ultimately, they do come down to community level, I suspect, and actually, how do we empower people at a community level to actually become the beneficiaries of community-based rehabilitation? Dr. Manga, if you can hear me, what are your thoughts on that? I think we can't hear you. No, are you? We're not getting your audio. Can you hear me at all? Can you nod? So you were perfectly clear a short while ago. No, nothing happening. Let me try another question for anybody on the panel. Just for anyone on the panel, what strategies would you recommend on how we actually achieve where we began, how we achieve the Sustainable Development Goal 3 with respect to rehabilitation? What strategies should we adopt? Smita, you've got a view on that.
Yeah, thank you very much, Mr. Burden. I would suggest a barefoot approach, to take the take-shift approach as a fundamental approach for community-based rehabilitation, because when we look at a community, people are bound to each other and they know their community very well. And so the issues the people face in that particular community is also well known to the local people. And if we are looking at a skilled professional, there is a scarcity, a huge scarcity of skilled professionals. So we have to train the locally available resources, and that will really benefit a lot. And it will also help us to get doorstep services rather than us traveling to a district level or to another state for rehabilitation purposes. Thank you. I think you are on mute, Mr. Burden.
Out of the session that you found some things which you can actually deploy and use in your work in the community in India. So that's a really positive that actually exchanging these ideas can bring good things. I would just like to bring in Mrs. Marx and also Dr. Alasos Cieza at the World Health Organization. At the end of the day, how do we mobilize adequate resources to respond to what is clearly a crying need for rehabilitation? Mrs. Marx and Dr. Cieza, what are your thoughts on that? Just taking a little bit of while just to engage. I'm going to bring them up on the screen.
Yeah.
Hello.
There
we are.
Yeah, thank you. So that is the most probably difficult question that one can ask in terms of rehabilitation. At the end of the day, it is a question of leadership, and really countries, seeing the benefit of rehabilitation and having political leaders in the health sector that see the benefits and prioritize rehabilitation. And of course, these need to be linked to a lot of work that needs to be done in countries, because we cannot ask and advocate for a certain envelope just for rehabilitation. We need to say, okay, what are the packages of care, what are the interventions that need to be funded and need to be part of universal health coverage, that need to be covered in the, for example, insurance schemes. And for that, we need really to define those interventions, these packages of care, costing those, and in order to move forward, so that also policymakers knows what they need to invest on. In order to mention that, or to bring some additional input on this, WHO, with actually over 500 professionals for around the world in the context of Rehabilitation 2030, and also with our development partners like Humanity and Inclusion and many others, we are developing a package of interventions for rehabilitation in order to achieve that, so that the countries can decide, look, these are the interventions that needs to be provided for this population. These are the resources that are needed in terms of infrastructure, workforce, and so on, that is needed to provide those interventions, so that also a budget can be and an envelope can be made. But the key for that, in order to move forward again, is political commitment of seeing the benefit for rehabilitation and committed to move forward with this agenda. Thank you.
Political commitment, a very strong point and a very strong message that comes out of this session. I'd just like to add that it does come down as well to community level and doorstep delivery. If we could just bring in our friend from Guyana, Dr. Manga, in terms of, I mean, you set out a very strong case of what your country, what Guyana is doing. How do we actually make this community level rehabilitation strong so it's effective? If Ariane Manga, if you're there, if you could tell us how we make it work at community level, please. We're just looking for your audio. You can hear me. Oh. Well, I think, no, we're not hearing, but you did give us a very good account of what Guyana is doing as a society. Can you hear me now?
Peter, if I can mention one thing that I didn't mention, that of course, again, the example that we have seen today of Guyana and Luxembourg on showing this leadership in terms of rehabilitation, it is the first step and to move this agenda forward. So emphasizing, and again, thanking both of them. Even if we have difficulty with the sound, we have seen grateful examples of what can be done when this political commitment exists in a country. So thank you for that again.
And thank you as well. I think I was going to ask you, as World Health Organization, whether you've been discouraged or encouraged by what you've heard in the past hour from around the world.
Of course, encouraged. You know, it is that rehabilitation is discussed in such a forum, in the high-level political forum, as integral part of universal health coverage, as really a key for achieving SDG3 and health for all. That is a dream that is becoming true. So in this sense, even if there is a long way to go, that this event is taking place is already a sign that things are moving and that are moving in the right direction. So for that reason, I think it is even, again, still many things to do, but it's music to to the ears of WHO to see this event. So thank you also to HI for organizing.
That is music to all our ears, and it's very good that we have the official endorsement of the WHO on this. But of course, we really we would like to focus on the work that Luxembourg is doing as well, our sponsors of this event, who've been very much a trailblazer for rehabilitation around the world. And I'd just like to talk to Mark Willier here. And Mark, if you could hear us, if you would just sum up exactly the role that Luxembourg is playing, and really what. Thank you so much for bringing us all together. From your perspective, what do you see as the role of Luxembourg going forward in rehabilitation?
Yes, thank you very much, Peter. I hope you can hear me.
Go ahead.
Yes, first of all, I would like to extend Marianne's apologies for the technical difficulties that we just faced. Please allow me to intervene briefly on behalf of Marianne and Luxembourg. So in response to your question, what I would like to add is Luxembourg is a proud founding member, together with the European Union, of the Partnership for Universal Health Coverage, a partnership that aims to strengthen the capacity of countries to develop and aim strong sustainable and comprehensive health policies, strategies and plans. So I think this is a very crucial aspect of our strategy, which contributes to rehabilitation services. But essentially, it's, most essentially, it's the strengthening of health systems that is key to ensuring rehabilitation. This is even more true in relation to underfunded and fragile health systems whose weaknesses have been prominently exposed by the pandemic. On another note, the promotion and respect of human rights is also essential for an efficient and sustainable rehabilitation, particularly, again, in fragile contexts, as women and young girls are disproportionately affected by poverty. Access to sexual and reproductive health and services, economic opportunities, and education are important key components for their rehabilitation. Maybe just very briefly, just to quote one example of a project that we implement. I mean, we have a very fruitful collaboration with Handicap International in Luxembourg, where we have successfully established a multi-year framework agreement for the years 2018 to 2022 that focuses on rehabilitation of persons with disabilities, notably on three main fronts. First of all, prevention and access to healthcare services and care, which have enabled to identify at an early stage already disabling diseases. Second, rehabilitation programs, including the development of community-based rehabilitation centers, while providing training to rehabilitation specialists. And then third, education and vocational training to improve the social and economic integration of persons with disabilities and their access to decent work. In this context, we have implemented two different projects, for example, one that was recently implemented in 2020, a humanitarian project in Libya, which we funded with 178,000 euros. The project has significantly contributed to prevent and reduce explosive ordnance-related accidents, for example, faced both by the conflict-ridden population of South Tripoli and by first responders alike. There was a second project, for example, that we implemented also in Myanmar that aimed to strengthen sustainable access to integrated and quality community-based rehabilitation services for mine explosive ordnance survivors and other persons with disabilities. So I think on the lessons learned from the pandemic, a last point that I would like to add, which is particularly important for donor countries, as NGOs in general were drastically affected by the ensuing COVID-19 crisis and partners were facing challenges to maintain operations, the importance of access to flexible and predictable funding has been clearly highlighted during the crisis. And in order to maintain their implementation of needs-based interventions, Luxembourg allowed NGOs, for example, to reprogram their foreseen activities and to reallocate funds towards the health sector to counter the pandemic. Those reallocations allowed NGOs to mitigate the risks of the pandemic on people in need of rehabilitation, and different initiatives emerged, such as the production of masks, awareness-raising campaigns on the virus, and food assistance, all to increase the resilience of the beneficiaries. So I think this pretty well, in a short way, sums up our main activities and how donor countries particularly can contribute to rehabilitation.
Mark, thank you very much. And finally, from everything you've heard, have you been encouraged by this last hour? We've heard from India, we've heard from Guyana, we've had research into COVID rehabilitation services. We've heard from Handicap International, Humanity and Inclusion. And of course, we've just heard from the good work which you're doing as Government of Luxembourg. Have you been encouraged by everything you've heard?
Yes, I think it's very important to tackle this issue from a multi-stakeholder perspective, to have not just one perspective as a donor country, but to include as many different stakeholders as possible to shed light on this crucial topic from different perspectives, and most importantly, to bring all the people together to work on solutions. I think it's only if all stakeholders work closely together in communication and exchange with each other that viable solutions can be created and viably implemented on the ground.
Mark, thank you very much, and thank you to all the good work which is going on around the world from the Grand Duchy and also from our panelists and from our audience. We still have well over 100 people listening into this, which I think is very good proof of how important this topic is. And before we go, I see Smita, you want to say a final word. Smita from Chennai,
yeah.
Go ahead.
Yeah, thank you very much. And taking from what Mark said also, like yes, the political, multi-stakeholder engagement is very important. And like Dr. Alaka said, political will. And the political leaders seem to be really encouraged during all these international discussions. But whereas when we come back to our own countries, it is not really getting implemented. What they promise is not really getting implemented. So what I would really like to appeal is that all the political leaders should engage all the multi-stakeholders, as Mark said just now, and we cannot have a one-point solution. So it has to be a multi-pronged approach. And yes, of course, health system strengthening from the base, from the community-based rehabilitation, community-based initiatives, and universal health coverage should cover all people's health requirements, including rehabilitation and palliative care. So public health financing is very important, as civil society engagement mechanism is promoting. So we have to have all these multi-pronged approach, so that we don't fail again when like we did during COVID. Thank you very much.
I think we have lost Peter right now. I'm very sorry for this. Please let me just take over briefly here and introduce Florence for the wrap up and the concluding remarks with regard to the discussion that we just had. I see Peter is back too. Can you hear us, Peter?
Yes, go ahead. Yes, I heard that. Florence, your concluding remarks, just to wrap up what has been a very fascinating session. Thank you.
Thank you, Mark. Thank you, Peter. And indeed, it has been a really interesting exchange. And I can propose to you 9 key takeaways that I would like to flag, resulting from this really thoughtful exchanges. One, the global need for rehabilitation is huge and is expected to continue growing, including in relation to COVID-19 and other infectious disease. So rehabilitation is thus crucial to respond to current health challenge. Second, the end or reduction of rehabilitation services during the pandemic compromise the health and functioning outcome of rehabilitation users and increase mortality. Continuity of essential rehabilitation services should be ensured during health crises. Third, despite all those evidence and consideration, health systems and response worldwide are still turned toward reducing mortality and morbidity. The third health indicators, functioning, which is a specific indicator for rehabilitation, often remain sidelined, and so do rehabilitation service. So fourth, rehabilitation is unavailable or unaffordable for the vast majority of the population who live in poverty, in rural areas, and in particular in low and middle income countries. Experiences of people with disability show that certain groups' barriers are even more difficult to overcome. This is true also for women and girls in many contexts. It is crucial to involve rehabilitation users in the planning and delivery of rehabilitation services. Fifth, good policies and practice exist. I think we all have been sharing experiences. When rehabilitation is integrated in health systems, access to services improve. With adequate political will, resources can be mobilized, the rehabilitation workforce can be strengthened, and more persons in need of rehabilitation can improve their functioning and participation. 6, international cooperation and humanitarian actors have a role to play, keeping in mind that rehabilitation is a lever to achieve SDG3 and other development goals. Since mobilization of domestic resources remain challenging in certain contexts, assistance conveyed via bilateral, regional, and multilateral channel is critical. 7, civil society organizations are also part of the solution. They act as providers of rehabilitation services, especially in fragile contexts and in time of crisis. They accompany government in the development of and implementation of rehabilitation policies and programming, with an important role to play, in particular at the community level. 8, there is need to promote an integrated, people-centered approach to rehabilitation, which rely on innovation such as telerehabilitation to maximize its impact and reach out to people in need. And as this year's, that will be my 9th and final point, as this year high-level political forum shed light on SDG3, let me end by saying that this goal cannot be achieved without accessible and quality rehabilitation service, and that health and well-being for all is often a precondition to achieve many other SDGs.
Florence, thank you very much. And on that very wise note, I think you've given us a real call to arms, a cri de coeur, as you would say in Lyon, of the crucial and central nature of rehabilitation. And I thank you all. And Mark, any final thoughts from you?
Thank you very much, Peter. Yes, I think having come to the end of the discussions now, I would like to sincerely thank, on behalf of Marianne Marks and Luxembourg, all the panelists for sharing with us their experiences and providing us with their valuable insights on this crucial topic. I would also like to extend our thanks to all the participants for their interest, hoping that they will be able to draw practical lessons of the discussions today. And then finally, I would like to warmly thank you, Peter, for your excellent moderation of this event. While this year's high-level political forum will highlight SDG3, the pandemic has reminded us that ensuring healthy lives and promoting well-being for all at all ages is of paramount importance, not only this year. Strengthening health systems becomes more than ever an imperative that requires adopting a comprehensive approach to the health and well-being of the world's population. It is important that those 2.4 billion people in need of rehabilitation, specifically those deprived of basic health services, will not be left behind. To conclude, if we want to achieve SDG 3 by 2030, ensuring rehabilitation services is not an option but a necessity. I would like to thank you all very much for your attendance and hope that you were able to draw very practical conclusions of the discussions today, and wish you a good rest of the day.
Mark, thank you very much. And just finally to say that this conversation, this session has been recorded and will be publicly available shortly. So thank you all very much indeed. I've learned a lot and I've been inspired, and I think it drives us all on to make greater efforts and greater strengths to actually put rehabilitation at the center of the SDG3. Thank you all very much. Good afternoon to you. Thank you.
Thank you.